Welcome to our channel. Today we're diving into the findings of the Charisma trial, which evaluated the combination of aspirin and clopidogrel in preventing cardiovascular events among high-risk patients. This trial has provided significant insights into whether dual therapy can offer more protection than aspirin alone. In patients at high risk for cardiovascular events, combining aspirin with clopidogrel did not significantly reduce the rates of myocardial infarction, stroke, or death from cardiovascular causes compared to aspirin alone. However, combination therapy did increase the risk of bleeding, raising important considerations for its use. Aspirin is known to prevent some cardiovascular events in high-risk patients. Clopidogrel, a P2Y12 receptor inhibitor, has also been shown to reduce cardiovascular events. While dual therapy is effective in acute coronary syndrome, its benefits in a non-acute coronary syndrome setting were uncertain before the Charisma trial. The Charisma study was a multi-center, randomized, double-blind, placebo-controlled trial that enrolled 15,603 patients with stable coronary artery disease or high risk for cardiovascular events. Patients were randomized to either aspirin plus clopidogrel or aspirin alone, with a median follow-up of 2.3 years, providing robust data for analysis. The primary outcome, a composite of myocardial infarction, stroke, or cardiovascular-related death, occurred at similar rates in both groups, 6.8% for combination therapy versus 7.3% for aspirin alone. There was a higher incidence of bleeding in the combination therapy group, particularly moderate bleeding, which was 2.1% compared to 1.3%. Post-hoc analyses suggested that symptomatic patients might benefit more from combination therapy, with fewer non-fatal strokes compared to aspirin monotherapy. However, these findings were not pre-planned and should be considered hypothesis-generating rather than definitive conclusions. The results of the Charisma trial have influenced clinical guidelines. For primary prevention, low-dose aspirin is recommended for adults over 50 with risk factors for cardiovascular events. Dual antiplatelet therapy is reserved for specific situations like post-stent placement or following a transient ischemic attack or stroke in some cases. The subgroup analysis was not pre-planned, making the findings less robust. Additionally, the trial included patients with varying degrees of risk, which might have diluted the potential benefits of dual therapy in a more targeted population. These factors should be considered when interpreting the results. In summary, while dual therapy with aspirin and clopidogrel did not significantly reduce major cardiovascular events in high-risk patients compared to aspirin alone, it did increase the risk of bleeding. These results suggest that dual therapy should be used selectively, taking into account the bleeding risks and specific patient profiles. Thank you for watching. Don't forget to like, comment, and subscribe for more insights into cardiovascular health and medical advancements. Stay informed with the latest in cardiovascular research and stay healthy. This is your source for trusted cardiovascular insights.